Thank you very much. Good morning, everybody. It's really an honor for me to join your Israeli Collaboration CTO meeting. Let me share the screen. The topic of my talk is about common and uncommon CTO PCI complication. So first of all, when we talk about complication, we have to divide that complication can be considered cardiac and extracardiac complication. Inside the cardiac complication, we have also to divide in non-coronary complication and coronary complication as well. And here are reported the incidence of each complication. So inside the extracardiac complication, you can appreciate that the most frequent complication is contrast-induced nephropathy. And about the cardiac complication, the most frequent complication, of course, is represented by peri-procedural MI. When we talk about coronary complication, you can appreciate that the most common complication that can occur during CTO PCI is represented by coronary perforation. And also we have acute vessel closure, but data are not reported about the real incidence of this kind of complication. And finally, equipment loss entrapment with a 1.5% rate of occurrence in this kind of procedure. Of course, it's very important to keep in mind that some of these complications are also related to different kind of approach that we can decide to use. And so we can have some complications that are related to the antegrade approach, such as aortocoronary dissection, equipment loss entrapment, main vessel perforation, or distal vessel perforation. At the same time, if we decided to go retrogradely, we can have also some complications that are specific of the retrograde approach, such as donor vessel dissection, donor vessel thrombosis, collateral channel ischemia, collateral channel perforation, and at the same time, equipment loss of entrapment through the collateral channel. If we start to talk about coronary perforation, we have to keep in mind that nowadays exists a contemporary classification that is quite different from the previous one that was made by Ellis. And now we can consider the perforation according to the site in which the perforation occurs. So we talk about main vessel perforation, distal vessel perforation, and collateral perforation according to the different kind of collateral we decided to cross. So we can have septal perforation and epicardial perforation as well if we decided to go through epicardial collateral connection. And exists also a dedicated universal algorithm that was recently developed by Manos Brilakis, and it consists in two different steps. The first one is a universal algorithm for each coronary perforation, and the first step is, of course, inflate a balloon to occlude the vessel. And if needed, to administer intravenous fluid, pericardiocentesis, if needed, notify the surgeon. This last step, it's not really, in my opinion, necessary, because I think that when we have this kind of complication, we should be able to solve it in our cath lab. After prolonged balloon inflation, in case of persistent extravasation, we have, of course, to go on with the second step, that is treat the cause with type-specific treatment that I will show you during my presentation. Interestingly, reverse of anticoagulation should be the last step. So in each kind of complication, the first step to do is inflate the balloon to stop the bleeding. So keep calm and stop the bleeding. This is just to let you to evaluate the situation, to decide which could be the next step to solve and to seal completely the perforation. After the first line strategy that is inflated, that it's represented by the inflation of the balloon, in case of persistent extravasation, as I discussed it before, we should go on treating the cause. And of course, treatment could differ accordingly to the different side of perforation. So in case of large vessel perforation or in case of distal vessel perforation. And as I underlined, reverse of anticoagulation should be the last step, because as a general rule, protamine should not be performed until removal of interventional equipment, because it's better an hemorrhagic complication, because it could be solved using performing an urgent pericardiocentesis, than a thrombotic complication, especially in the donor vessel, that could be catastrophic. So Keep calm and choose the lesser of two evils. No protamine until the end, until you remove all the gears. Regarding the treatment, several strategies have been described during the last few years. And recently, all of this technique that was described to solve and to treat and to manage coronary artery perforation have been unified or under a single definition, that is block and deliver technique, and could be applied even if we have to deliver a covered stent or to decide to deliver coil. And I'll try to show you into the next slide. So when we have to go on with the type-specific treatment, of course, in case of large vessel perforation, this is a situation that often require delivery of covered stent. If after prolonged balloon inflation, we can observe a persistent extravasation. To deliver the covered stent, basically we have two different techniques. The standard technique, it's also the most widely adopted technique, that it's called the dual catheter technique. But at the same time, recently it has been described by Manos Brilakis as single guide catheter technique to solve this kind of perforation. But the need for a single or dual guided catheter technique, it's also related to the guide catheter size that we are using. So if we start to use a 5, 6, or 7 French, this is a situation in which we should use the dual guide catheter technique. The opposite side, if we started to perform the CTO PCI using an 8 French, in this case, with the new covered stent, single layer stent, for example, the big graft stent, it's possible to deliver the stent using a single guide catheter technique. And in my opinion, despite the single guide catheter technique, it's very simple and friendly, user-friendly. I think that we should keep it simple. So in this case, the most reliable and the most safe technique is to adopt the dual catheter technique when we have to decide to deliver a covered stent to cover a perforation, like in this case. Because if you have a main vessel perforation, the first line strategy is to inflate the balloon. At this time, you can pull back just a few centimeters the first guiding catheter, leaving the balloon inflated in order to stop the bleeding. In this case, you have all time to take the second access or to advance a second guiding catheter into the coronary ostium, to advance a second wire. Over the wire, you should advance the covered stent. So you can advance the covered stent through the second guide, leaving the balloon inflated. When the covered stent is very close to the perforation site, at this point, you can deflate the balloon, remove the balloon, and remove the guide wires, and finally deliver inflated the stent and cover completely the perforation. This technique reduces dramatically the likelihood to develop a cardiac tamponade, because you leave all the time the balloon inflated until you are in the right position with the covered stent. You can deflate the balloon just for a few seconds, remove the balloon and the wire, and inflate the covered stent. So no need for urgent pericardiocentesis if we adopted this technique. At the opposite side, this is the summary of the single guide catheter technique described by Manos Brilakis. If we are using a 8 French or even 7 French, if the single layer stent are available in your cath lab, you can advance at the same time through the same guide catheter the balloon for occlusion to stop the bleeding. Then you can advance a second wire into the same guide catheter with the covered stent. And finally, the technique is the same. Once you are very close to the perforation side with the covered stent, you can deflate the balloon, you can remove the balloon and the first wire, and then you can inflate the stent. So this is also the single guide catheter technique, but I think that it's simplest to use the dual catheter technique once you have to deal with the main vessel perforation and once you have to advance a covered stent. Differently, in case of distal vessel perforation, of course, we have other technique. Another technique could be also represented by the lever cover stent over perforated branch origin, but honestly, I don't like this kind of technique because it's not really conservative. You create a big exclusion of the perforate vessel, and you can also create a periprocedural MI. So I prefer to embolize the perforated vessel. And there are several embolic agents, but honestly, I suggested to use the detachable coils because are really reliable. And once you become confident with this kind of technique, it's quite easy and faster and safe to deliver coil. So honestly, the lever coil is the most reliable strategy to manage distal coronary perforation. And nowadays, the most widely and universal adopted technique, it's represented by the technique that we described 4 years ago. And now it's called block and deliver technique. So once you experience a perforation, you should inflate the balloon to stop the perforation and then advance a second wire with a microcatheter. Once the microcatheter is close to the balloon, you should, of course, deflate the balloon in order to let the advancement of the microcatheter close to the perforation side. Once you reach the perforation side, you leave the balloon inflated and you can deliver an advanced coil without the need to deflate the balloon. Of course, even in this case, you should check for the compatibility because the coil that are available in your cath lab should be compatible with the microcatheter that are you using. So in this table, you can also check, and this is a summary of all the availability, but I strongly suggest that if you have the opportunity to having available in your cath lab the coil that are 0.010, this come from the neuroradiologist, of course. This kind of coils could be inserted in all the microcatheter that we use during the CTO PCI, because of course the microcatheter is compatible with the guide wires that are 0.014. So 0.010 microcoil are of course compatible with all the microcatheter. So in case of collateral perforation, the treatment can differ if we are talking about septal or epicardial collateral perforation, because usually septal perforation are self-limiting. So the first strategy is to wait and see, because as I said, they often don't create any hemodynamic consequence. So in case of doubt, of course, you should go on with embolization, but the first strategy is to wait and see. Differently, in case of epicardial collateral perforation, this kind of complication can lead to a rapid hemodynamic deterioration, and they need for a prompt intervention, such as distal embolization. So, of course, also in case of collateral channel perforation, treatments can differ if we are successful reopen the CTO vessel, so the CTO target vessel, or in case of perforation before reopening the CTO vessel. So in case we successfully reopen the vessel, we have to go on with distal embolization from both sides, because the feeling, as you can appreciate here, arises from both vessels, donor vessel and target vessel. Differently, if we have a perforation before we open the CTO, embolization from both sides is of course impossible. And so we have to embolize only from the donor vessel. And sometimes it's enough to stop the bleeding, because the low pressure coming from the target vessel does not really create a cardiac tamponade. But sometimes, if you are not able to stop the bleeding, you should send the patient to the surgery. And this is an example of distal coronary perforation. This is an example of collateral, epicardial collateral perforation. We adopted the block and deliver technique. We inflate the balloon. We advanced a microcatheter. You can appreciate here the tip of the microcatheter. Through leaving the balloon inflated, a coil was advanced to seal the perforation. After that, you can check from the micro directly with a tip injection the effectiveness of embolization. In case of persistence and travasation, you can deliver a second, a third, a fourth coil until you are sure to achieve a complete sealing of the perforation. This is very important because advancing the microcatheter and the coil does not need to deflate the balloon. And if you are able to perform immediately this technique, inflating the balloon as a first step, you don't need to perform an urgent pericardial changes. Differently, if you have an epicardial collateral perforation, when you reopen the vessel, as I said, you should go on with embolization from both sides. So in this case, there is a filling from the right and also filling from the left system. And we inflate a balloon for occlusion in both vessels. And of course, you create ischemia, so you should be very fast. You have to re-engage the perforated collateral. You can perform a tip injection from the micro, leaving the balloon inflated. And also through the micro, you can deliver the first coil and you check for the sealing. After sealing from the target, you should go on from the donor. At the same way, leaving the balloon inflated, you can advance a wire, you can advance a microcatheter, you perform a tip injection to identify the right position of the collateral perforation, and then through the microcatheter, you can deliver the coil, achieving a complete hemostasis of the perforated vessel. So when we talk about coronary complication, of course, there are not only perforation, but also acute vessel closure and also equipment loss entrapment. As I said, there are no data reporting the real incidence of acute vessel closure, but there are several techniques that can be adopted to solve this kind of complication. And there are reported in this paper from Lorenzo Azzalini. And of course, all of these techniques should be well known by CTO operators because are mainly represented by dedicated CTO technique. When we talk about other complications that are specific from retrograde approach, we can talk about donor vessel dissection and donor vessel thrombosis as well. So the donor vessel dissection, it's very important, and all the operators should check for the integrity of the donor vessel before removing the retrograde gear, because sometimes could be a catastrophic situation. In this case, we performed a retrograde LAD CTO PCI. We were very happy to achieve this kind of result, but unfortunately, we missed to check for the integrity of the donor vessel before removing the retrograde gear. And as you can appreciate here, there was proximal dissection on the right coronary artery without a safety wire inside. So we have to recross to regain the distal true lumen to deliver a stent. So before removing the retrograde gear, operators should check for the integrity of the donor vessel, because sometimes you can create some damage of the donor vessel or some dissection, like in this case. At the same way, another dramatic complication that can occur during retrograde CTO PCI is the thrombosis of the donor vessel. So for this reason, you can appreciate after retrograde LAD recanalization, we notify a big thrombus into the mid-distal part of the RCA. So it's very important during CTO PCI to check for the right value of the ACT. In case of antegrade approach, you should check every 30 minutes in order to have more than 250 values of ACT. And during retrograde CTO PCI, you should check every 20 minutes to have more than 350. So you should not be afraid to administer heparin if the ACT value is not the therapeutic one, because a thrombotic complication could be really catastrophic. Of course, if you go retrogradely, you can also have another complication, that it's the collateral channel ischemia. You can see this RCA CTO with this big and tortuous collateral channel, epicardial collateral channel. So after checking for a connection of from septal, there were no way to go from septal. We decided to go through this epicardial collateral channel. But of course, once the wires crossed the epicardia, we had an accordion effect that stopped completely the retrograde filling of the RCA. So the patient developed an acute MI, inferior MI, followed by ventricular fibrillation that needs some resuscitation maneuver. So in this case, you should remove all the retrograde gear in order to restore the retrograde filling of the target vessel, and you can solve the situation. Sorry for that. Okay. Regarding the equipment loss of entrapment, this kind of complication can occur even if you go antegradely or if you go retrogradely. And we recently published our experience collecting data, more than 2,000 procedures by 5 high-volume Italian centers. And as you can see here, device entrapment occurring in 36 out of more than 2,000 procedures with an incidence of 1.5%. And the most frequently entrapped device was represented by guide wires entrapment, followed by rotabur entrapment, and then balloons and microcatheter entrapment. And we reported our data. We were able to perform a successful percutaneous retrieval in more than 97% of cases. This means that this kind of complication should be solved percutaneously without need to send the patient to the surgery. And at the same time, despite this cumbersome and life-threatening complication, we were able to achieve a technical success rate of 86%. That means that we were able, despite the complication, to reopen successfully the CTO. The MACE was about 11%, and it was, of course, mainly represented by periprocedural myocardial infarction. And you can appreciate that more or less the rate of device entrapment that occurred during antegrade are very similar to the rate of device entrapment that can occur retrogradely. So what are the main causes of device entrapment? It's represented by attempt to deliver equipment via tortuous and calcified vessel, of course, or when the operator apply an excessive torque to the guide wires. When the tip of the guide wires is entrapped in the CTO, this can occur quite frequently with the Gaia wire. If you apply a torque to the Gaia wire and the tip of the Gaia, it's stuck into the lesion. Or in case of aggressive advancement of a rotational atherectomy BURR into the CTO, into the plaque, into the calcified plaque, or rotation applied to a knuckle wire that can create some node. Rotation applied to a non-rotatable microcatheter. This is a very important and frequent complication if the operator does not know very well the technical feature of each microcatheter, or during an attempt to deliver equipment via very tortuous and tiny collateral channel. And the last but not least, when the antegrade gear meet the retrograde microcatheter over the same guide wire. This is a dramatic complication. During our paper, we also try to propose an algorithm to solve this kind of complication, and we can resume that the first strategy maneuver is to try to apply a gentle pull to the device entrapment. So pulling is the first strategy, followed by trapping, the trapping technique, the telescoping technique that consists in advanced guide catheter extension very close to the entrapped device in order to improve the force, the pulling force to the system. The snaring, and finally the last technique, it's a plaque modification technique that consists in try to perform an balloon inflation very close to the device entrapment in order to free it from the vessel wall. I have now some example. This is a knot that we had during a retrograde attempt during a knuckle wire. This was a Gaia wire that was knuckled, and we have a knot of the wire that led impossible the retrograde retrieval of the wire. So in this case, we went through a very tiny and tortuous epicardial channel, so no need to remove the wire with the knots because of safety reasons. So we decided to go on with a controller rapture. We create a controller rapture, pulling the wire into the microcatheter, and after that check with IVUS to be sure to have a complete coverage of the fragment of the wire by the stent. With this final result, And because a tip fracture frequently leads to unfolding of the tip coil, so a sort of decoiling of the wire, it's very important to check for a complete sealing of the wire. This is another example of the wire knot, retrograde wire knot. So operator tried to remove all the retrograde system, but the wire gets stuck into the septal, so there is no way to remove by pulling. So it tried to force the pulling, but finally he experienced wire decoiling. So you can appreciate here the coil wire that is inside the cardiovascular system, and you should remove it because the risk of thrombogenic effect if you leave this coil wire inside the vessel, of course. So the first attempt was by wire trapping, but it was not effective. As you can appreciate here, we inflate the balloon over the core wire, but it was not successful in terms of the retrieval of the wire. So the second attempt was performed by snaring, but even using the snaring, we were not able to remove the core wire. And the fourth strategy that we applied was the plug modification technique. We advanced a second wire close to the device entrapment. We inflate the balloon, but also in this case, it was not possible to free the wire from the vessel wall. And finally, the last and successful attempt was performed using the radial axis in order to modify the force applied to the core wire. And using snaring, we were able to remove the core wire, leaving this fragment of the wire into the septal. And of course, also we have to cover the fragment at the level of the left main. So we were able to solve this dramatic complication without the need to send the patient to the surgery. Here I reported a microcatheter tip fracture that can occur, especially if you advance a microcatheter with a soft tip or not rotatable microcatheter. For example, this is a Caravel microcatheter. So the Caravel microcatheter is an excellent microcatheter to use, especially when you have to cross the epicardial collateral channel for its safety. But it's not the best microcatheter to advance and to force it into a calcified lesion, because the tip is very gentle, it's very soft, and also is not a rotatable microcatheter. In this case, the operator forced the advancement and tried to rotate the microcatheter, and finally he had the tip fracture of the tip of the microcatheter. Of course, as I discussed, you should know different technical features of the microcatheter, because if the structure of the microcatheter, it's a coil, so the microcatheter, it's called coiled microcatheter, such as the Corsair Pro, for example, you can rotate it without any problem. But if the structure, it's a braided structure, such as fine cross of Caravel, for example, you cannot rotate it because you can destroy the microcatheter. So it's very important to know the technical feature of each microcatheter in order to know the best way to manage it, to handle this kind of microcatheter. But you can also experience a tip fracture of a strong tip microcatheter and rotatable microcatheter such as Corsair, of course, because if you try to force the microcatheter into a calcified lesion, even if you are advancing a rotatable microcatheter, you can also have a device entrapment into the plaque, into the CTO body. And in this case, operators solved the situation with the strong force, pulling in all the retrograde gear, and he had this septal perforation, of course, fortunately without any hemodynamic compromise, because it was at the level of the septum. But you can appreciate here the tip of the microcatheter that was completely destroyed by the attempt to force it into the calcified lesion. And another most frequent complication that we experience in our series, in our data, was the BURR entrapment that occurred in 10 cases, because of course we are treating very complex lesions such as CTO PCI, and sometimes in about more or less 30% of cases with severe calcification. So need for rotablation, it's quite frequent in this kind of procedure. This is a LAD, not very long, but the wire was quite easy and successful. And after that, no way to dilate with the balloon. So we decided to go on with the rotablator. After 1.25 millimeter, we decided to go up with the rotabur 1.75 that's taking the proximal LAD. So this is a video very explicative of the technique, of the telescoping technique. Of course, you should cut the rotablator catheter. After that, you should remove the dry shaft. And once you remove the dry shaft, you can advance over the remnant part of the device. You can advance a guide catheter extension very close to the entrapped BURR. You can appreciate here the tip of the guide catheter extension. And in this case, the force that you can apply in terms of removal of the entrapped rota or of the entrapped BURR, it's very high. And you can remove successfully and in a safe way the entrapped BURR. This is a very effective way that we perform in 9 out of 10 case of rotabur entrapment. This is the other case in which this kind of technique was not applied, and the operator decided to apply a different technique. It was a very calcified LAD CTO. Finally, he went anti-gradely using the retrograde technique as a landmark technique. He performed a rotablator and the bar stuck into the distal LAD. So it tried several attempts to withdraw the bar, and finally the only that was effective was to advance the second wire, performing a plaque modification technique, and he was able to inflate the balloon across the site of entrapment in order to let the bar to be free from the arterial wall, achieving a successful management of this kind of complication and also a successful recanalization of the LAD. So, of course, similar to non-CTO PCI, procedural complication of CTO PCI can arise from different sources, and it's not surprising that this kind of complication, the rate of this kind of complication could be higher in this kind of procedure, and the operator experience, it's essential to be able to recognize this kind of complication and to be able to manage and to handle all of these complications that can occur during CTO PCI. So the key point is that when you have to plan a CTO, planning for CTO means also planning for treating complications should they occur. Thank you very much for your attention.